So much of what we do as breast oncologic surgeons is linked to the systemic therapy our patients receive. We undertook the current study to assess breast and axillary surgery outcomes in the Daphne trial, which was a prospective single-arm multi-institution feasibility trial that examined patient and provider acceptance of a pathologic complete response-driven approach, treating HER2-positive breast cancer patients with a de-escalated neoadjuvant regimen of THP, Taxol, Herceptin, Pertuzumab, alone, and then no further cytotoxic chemotherapy for those who experienced a PCR. We embarked on the current study because what we don't want to see happen is that we successfully de-escalate systemic therapy but inadvertently escalate surgery. In other words, we don't want to optimize systemic therapy regimens at the expense of local regional treatments. Regarding the breast, 55% of patients underwent breast-conserving therapy or BCT. Of the 39 patients who were eligible at presentation, 85% underwent BCT. Of the 53 who were not eligible, 25 had relative or absolute contraindications like prior radiation. But of the 28 who were potentially eligible with downsizing, 22 became eligible and 82% of those underwent BCT. These really are quite high BCT rates. Regarding the axilla overall, 84% of patients underwent sentinel lymph node biopsy. There were only 8 axillary dissections performed for residual nodal disease, 3 in the CN0 population, 5 in the CN1. These numbers are really similar to reports after standard regimens. Given the feasibility seen in the Daphne trial, treating with THP alone, a large cooperative group clinical trial was launched out of ECOG Akron by Dr. Nadine Tung, one of our co-authors. This trial is called COMPASS PCR. It is similarly treating patients with THP alone, but this time the primary endpoint is recurrence-free survival among the patients who experience a PCR. Surgeons should feel comfortable enrolling on this trial and others like it, doing the same surgery they would do after any neoadjuvant regimen. Breast-conserving therapy if the patient becomes eligible, sentinel node biopsy to start, and axillary dissection based on the presence or absence of residual nodal disease.